A very good morning and a warm welcome to all of you. In this Sunday morning, on behalf of Mylan family, I would like to welcome you all for this webinar. But before talking about this webinar, I wish and I hope that you all are safe and healthy from this pandemic. My sincere thanks to all the doctors who have joined this webinar. If I say in Hindi, हृदय से नमन आप सभी को who are true warriors in white. So thank you so much to all of you doctors. Let me come back to this webinar topic. This webinar topic is also somehow related with this pandemic. We are very thankful to Dr. Divya Sharma, who is our speaker for today, who is accepting a request for being a speaker for this topic. Dr. Divya Sharma will be speaking on care of for patients with atopic dermatitis during this pandemic. That's what I said, that it is somehow related with this pandemic as well. Dr. Divya Sharma is an eminent and proficient dermatologist with a wide experience in the various fields of dermatology. Madam, thank you so much for joining here as a speaker. A little words about Dr. Divya Sharma. She is a chief consultant dermatologist at Dr. Divya's Skin and Hair Solution. She has a special interest in clinical dermatology, cosmetic dermatology, trichology, pigment disorders, pediatric dermatology, STDs, leprosy, and lasers in dermatology. I just would like to quote one important paper that she has published in International Journal of Trichology. The paper named Clinical Investigative Profile of Patients of Hirsutism in a Tertiary Level Institution. I'm proud and privileged to introduce Dr. Divya Sharma as a speaker for this webinar. Madam, once again, thank you so much to you, and it's all yours.
Thank you, Mr. Vikram, for such a warm introduction. And I'm very thankful for all the doctors that are joining us on a Sunday morning for this knowledge sharing platform. So, my topic for the webinar today is care for patients with atopic dermatitis during the COVID-19 pandemic. As we all know, not taking much time, I'll come to the topic itself. Atopic dermatitis is a common chronic relapsing inflammatory skin disease that primarily affects young children. It was actually a misnomer when it was called an allergic pandemic because we have seen a substantial increase in the prevalence between 1950s and 2000 due to rapid industrialization. There are two main hypotheses which talk of, the pathogenesis of atopic dermatitis. One is the immunological hypothesis that it's, as we all know, the immunity has two legs. One is Th1, which fights with infections, and Th2. So the CD4 T cells, they actually differentiate into Th2 subtype, leading to an increased production of interleukins, especially interleukin 4, 5, and 13, which leads to an increased level of IgE. Interleukin 31 is known as the pruritus-specific cytokine. The second hypothesis is that atopic children are born with the deficiency of filaggrin. So this gene is not normal in these children. We all know that filaggrin is broken down into profilaggrin, and profilaggrin makes the natural moisturizing factor. So there is a genetic defect there. There are a lot of genetic defects which have been discussed in literature, which explains why these children are predisposed to dry skin. Coming on to the disease burden of atopic dermatitis, it is one of the most common skin disorders. If you look at the Indian data, the mean age at onset and the mean duration of disease were 4.2 and 3.3 months, respectively. In the infantile age group, I'll be talking about how we differentiate atopic dermatitis according to age in my next slides. And childhood atopic dermatitis, where the mean age at onset was 4 years and around, and the duration of disease was 1.9 years. The infants generally see more facial involvement and we see more acute eczema. So what do we understand by acute eczema? We would see children with oozy lesions. We would see children with, itchy lesions which are scaly. Whereas in childhood age group, it was more of a chronic thing. Atopic dermatitis in itself keeps on showing exacerbation and remission. Few bad prognostic factors is if there is a family history, it is very important for us to take a history, whether the parents or the grandparents or the first generation cousins have a positive history of atopy, early onset of atopy. If it's a female gender, though Indian studies have found more prevalence in male gender compared to female gender, but international literature talks of female gender as a poor prognostic factor. And of course, atopic triad. So atopic triad includes not only eczema, it also includes allergic rhinitis and asthma. So at least 90% cases or so are seen in less than 5 years. And I think we all practitioners will agree that we see mostly patients in mild to moderate severity. The severe form of atopic dermatitis is thankfully rare. Now, 25% of patients may have atopy persisting into adulthood. So we see a lot of adult patients coming with specific presentations like hand eczema or nipple eczema, specifically in women. That's a marker of sometimes late onset atopy. Now, what are the main clinical features of atopy? For information of all, the first and foremost clinical feature that should be emphasized in every atopic patient, that is pruritus or itching. So we also refer to atopic dermatitis as an itch that rashes and not rashes that itch. That means when we are treating an atopic patient, treatment of itch is of paramount importance. Second is, of course, xerosis or dryness. And third is the skin lesion. There have been many diagnostic criteria proposed for atopic dermatitis. We dermatologists have always read and talked about Hannifin and Rajka criteria, but American Academy of Dermatology has given a new diagnostic criteria where the essential feature of diagnosing a patient as atopic dermatitis is itch and eczema with the typical morphology and age-specific pattern. Important features could be the early age, the family history, and the dry skin. And the associated features could be, keratosis pilaris, facial pallor, dermographism, ocular changes. They generally have a darkness around the eyes. They have a pallor around the mouth. So all these are not primary but secondary features when we want to diagnose an atopic patient. Now, how do we clinically stage? And in this presentation, I will be actually dividing my patients into 3 age groups. One is atopic dermatitis of infancy. So as we can see, these infants generally present with lesions on the face. They may come with scalp. They may come with severe cradle cap. They may come with lesions on the extensor aspect. In atopic dermatitis of childhood, which is between 1 to 5 years of age, we see sort of more lesions on the folds of the body. And the eczema is also drier and it is more thick and lichenified lesion compared to an infantile age group where we may see a lot of oozing as well. And of course, there is atopic dermatitis of adulthood and adolescence. This is a little tricky thing to diagnose because many, clinical lesions can mimic atopic dermatitis of adulthood. But generally, we see a lot of patients on face, neck, head and neck dermatitis. They may masquerade as contact dermatitis, or sometimes they may even be misdiagnosed as nummular eczema or seborrheic dermatitis. But of lately, since the COVID-19 has started, I'll be talking about, we see a lot of patients of hand eczema. So an adult patient can also present primarily with something like a recalcitrant hand eczema or a severe nipple eczema. What is the aim of treatment in atopic dermatitis? I always stress upon, and I always think in my practical experience, that more than improving the appearance of skin lesions, it is the itch that is the main problem. And, we cannot cure atopic dermatitis. It is very important for us to make the parent, the caregiver, and the patient realize the importance of maintenance treatment, the importance of adapting to certain changed lifestyle. So we try to minimize the number of exacerbation. We try to reduce the degree and duration of the flare. But the first aim of treatment in any atopic patient is primarily prevention. The second aim is treatment. Now, conventionally, I'm just taking everyone through a bit of the introductory part of atopic dermatitis before we come to the main topic. Most important thing is how did we manage atopic dermatitis in pre-COVID era? We have the non-pharmacologic options and we have the treatment options. So in non-pharmacologic, and which is the most important part of managing an atopic dermatitis patient, is use of moisturizers, is use of barrier creams and bathing practices. Now, the general consensus, there hasn't been any consensus on the bathing guidelines. We have never got a guideline that has established how we should take bath when we are an atopic patient. But the consensus is that a 5 to 10 minute bath with the lukewarm water, and most importantly, the soak and seal approach, means you have to tell the patient to moisturize and immediately pat dry, never rub the skin, and seal it with a moisturizer. So this is very important, and I think it is a pillar of treatment of atopic dermatitis. It has assumed a new importance in COVID era, the non-pharmacologic management of atopic dermatitis. Of course, conventionally, we have used topical agents like our topical corticosteroids, calcineurin inhibitors. I'll be talking about them in detail. Antimicrobials are used especially in lesions which are infected, because a bacterial infection is a common cause of exacerbation of atopic dermatitis. And hence you do see and talk and hear a lot about bleach baths or sodium hypochlorite baths, which help in reducing the colonization of Staph aureus. It's a common bacteria, we all know of it. And if an atopic patient has an infected lesion, possibly we have to first treat the infection, then to manage the skin lesion. Crisaborole is a new topical phosphodiesterase 4 inhibitor. It has recently cleared the phase 3 clinical trials and shown efficacy. Coming to moisturizers. So I often come across, before we go to the main topic, I would like to, quickly take everyone through what do we mean when we say prescribe a good moisturizer to an atopic patient. So there are three types of moisturizers. One is the occlusive moisturizer. So occlusive moisturizer, as the name suggests, it basically forms a layer on top of skin. It prevents the evaporation of moisture to the environment. So we generally, take only occlusives as moisturizers. So most commonly you see petrolatum, you see paraffin, you see coconut oils and lanolines. They're all examples of occlusive agent. Second group is humectant. What are humectant? Now we all know skin has got 2 to 3 layers. So humectant attract water from down the skin. So if you have a humectant, it will try to absorb moisture from the dermal part. It will also try to absorb moisture from the environment. Glycerine is a very good example of humectant. And third is emollients. Now emollients are basically something that is going to go into the skin and replenish the barrier. We all know that skin is like, we call it a brick and mortar arrangement. You have skin cells and you have a lipid barrier. So emollient is something that's going to go and fill up the gaps in those lipid barrier, and the essential fatty acids or natural lipids are an example. So it's very important. There is no consensus which moisturizer is best for atopic dermatitis, but we generally say emollient with a occlusive or a humectant is the something that combines both of them. If the skin is too dry or scaly, then occlusive component should be higher. But in my practical experience, I think emollients is what is the game changer in atopic patient. Now, wet wrap therapy, I mean, there's a lot of literature available. What is basically a wet wrap? You moisten the dressings, you wrap it around the affected area, you wrap a dry dressing on that wet dressing, and then you may ask the patient to put on nighttime clothing, something which is non-pharmacologic, but it will assume importance in the COVID era. Now, systemically, for patients who are not responding to topicals or a very severe form of atopic dermatitis, we have to opt for following systemic options. Narrowband phototherapy and UVA1 has been used. Cyclosporine is primarily used in European countries. Azathioprine is the third line therapy along with methotrexate and mycophenolate mofetil. Strangely, FDA has only approved systemic steroids and this molecule known as dupilumab. Now, this dupilumab, if you remember, I had talked that interleukin 31 is the itch-specific cytokine. So dupilumab inhibits interleukin 31 and interleukin 4. So it basically prevents the cytokine storm. And cyclosporine is being used now even in COVID era. In certain studies are pointing towards the beneficial role of cyclosporine, especially in reducing the cytokine storm. So we talked about the topical anti-inflammatory therapy. Emollients, as I already told, we don't have a consensus how much, but in general, we tell the patient to apply moisturizer at least twice a day and best when used after the bath. It is very important for a general practitioner friends to know that before prescribing an ointment, we have to emphasize to the patient about the good use of emollient or moisturizer. It has been seen that there is a relative risk reduction of up to 50%, and in my practical experience, it's even more. So we talked about what are the limitations of topical steroids. We all know it's the first line treatment to bring the flare down. There are many different formulations, different potencies, depending on the area. So if you're prescribing a steroid for a face or a neck or around the eye, it has to be very mild potency. Whereas for flexures and for elbows and knees, you can always go for mid-potent to high potency steroid, but it should be a short-term treatment. Why it should be a short-term treatment? Because we know steroids can cause atrophy. They impair the barrier. I'll be talking in detail. There is a risk of tachyphylaxis, means they stop working after a while and patient comes back to you saying that it's not helping me at all. And now with the Google era, we have a corticophobia, it's very important to address corticophobia in any parent or caregiver of atopic patient when they first come to you. So topical calcineurin inhibitors, I feel, actually has been the first major breakthrough in eczema in 50 years ago, where Dr. Sulzberger had discovered pimecrolimus and tacrolimus, and they isolated it from a bacteria. And how do they act? They basically decrease the NF-18 nuclear factor activated transcription, reducing cytokines, and they also act on these vanilloid receptors, reducing the itch and inflammation. Now, if you compare tacrolimus and steroids, why I'm talking of it is because as we subsequently go through our presentation, we would realize the importance of, I want to give a little introduction for my colleagues who are not dermatologists. So all of us know that steroids act on all cells. They also act on keratinocytes. They cause atrophy. They act on eosinophils and fibroblasts as well. Pimecrolimus and tacrolimus are more specific for the inflammatory cells. So they're more selective in their action. Now, coming to COVID-19, we all are battling an unprecedented situation. It has made significant consequences on general health, physical health, mental health, economic health, and of course on chronic disorders like atopic dermatitis, which in itself is a barrier repair disorder. The main route that has been seen till now is through respiratory droplets and close contact. And we have seen it hasn't been, as of now, till the time I present the webinar, skin is not a common portal of entry, but touching and then, touching the face and mouth, as we all know, could be a possible entry route. Mucosal membranes are the most common entry, including conjunctiva. It's very important for us to wear goggles along with the mask. And otic canal is seen to have the lowest risk of transmission. So skin per se has not been seen as a portal of entry. So whether atopics are predisposed to get more COVID than people who do not have atopic dermatitis is still an enigma. Now, what are the challenges ahead? Now, in COVID-19, there are some physiologic changes expected in atopy per se. There have been a change in behavioral patterns, and of course, we have compliance issue. Now, I'll be talking of them one by one. What are the physiologic changes that you expect in an atopic patient? Now, of course, theoretically, if you have a compromised barrier of skin, that could serve as a portal of entry of viral infection. As of now, not seen, not such specific cutaneous manifestation, but yet to see. COVID-19 quarantine basically has caused some amount of stress to everyone, and we know the neuroendocrine axis, how mind works with skin. So it could also lead to an increase in itching in atopy. Of course, with quarantine comes less exposure to sunlight, along with high temperature and low humidity. And we also feel, though the patient is not exposed to outdoor pollution, it is the indoor pollution that has always been a problem with atopic patients, especially tobacco smoke, volatile compounds, most importantly, house dust mite, pet dander. So there is more exposure to such indoor pollutants which can exacerbate or trigger atopy. Now, what are the behavioral pattern? So first and foremost important, actually, I would say altered bathing practices. We do prescribe and advocate hand hygiene, but as Indian patients, we do see people are spending more time in taking bath. There is a predisposition to use more soap and rub and scrub more. Also in India, sometimes people like to add disinfecting agents like Dettol or Savlon also sometimes, especially the ones who go out to work. And of course, so with this we do see that already if a patient has a compromised hydrolipid skin mantle and patient is taking overbathing, we all know that's going to cause exacerbation. So this has been one fundamental behavioral change in people. Also sitting at home, frequent lockdowns, people are eating diet which is very rich in saturated fats and refined sugars. There is a reduction of physical activity, and we all know that bad lifestyle and obesity can always trigger the Th2. That's why we see more allergic diseases in people who are well-to-do and urbanized. So increase in obesity may also trigger an exacerbation. Then, of course, the economic this thing is that people cannot come to you so easily. There is an access issue. There is somewhere even access to medications. They may not get the proper prescribed medications. Some people, because of the I would say covidophobia, have also stopped taking immunosuppressive medicines because they fear they may contract COVID-19 more. So we'll be talking about that in detail. So these are the behavioral changes expected for every age group during the COVID-19. And let me talk about age-wise. So in infantile age group, what we can possibly see, and which we have started seeing in our practice, there is definitely an issue of infrequent visits because people, they're scared to bring small children to clinics and hospitals. So this may mean less compliance to treatment. It's also very difficult to follow up a patient if you have put a young child on a systemic therapy. There is also less compliance to non-pharmacologic interventions like moisturizing and bathing practices. And one practical aspect I'm seeing in my practice these days is that both the parents are working from home and they say they have no time. There are, the nannies are not coming. So practically even that is going to impact the non-pharmacologic management of my patient. One important thing that I have come across is that in infantile age group, people generally tend to frequently oil the head of the child. So if the child is already having cradle cap, or if the child is, being oiled frequently and the scalp is not washed, there is a theory, and in our practice we do see that it aggravates the seborrheic capitis or cradle cap. And whenever the cradle cap is severe, there will be an activation of IgE, which leads to exacerbation of atopic lesions as well. So we do see, and I think most of my dermatologist colleagues will agree with me, that we do see a lot of atopic dermatitis, seborrheic dermatitis overlap these days. So it's very important that we proactively reach to the parents and sensitize them to maintain the skin barrier and continue the treatment. The challenge in a childhood age group is, of course, as I talked, that now because children are sitting indoors, there's no school time, playtime, they have more exposure to indoor pollutants, house dust mite, pollen, and dander and pet dander. There is a lack of physical activity. So, as I said, if the child is gaining weight, it can aggravate atopy. Overzealous bathing or cleaning by the parents. Stress can activate itch receptors. We all know that stress always aggravates atopy. Stress always aggravates itch, no matter what. So delay in seeking treatment is common. And as I said, in urban cities, working parents have less time. It also could mean that there is an economic impact of the disease. So there could be a possibility that they cannot afford expensive moisturizers and treatments. The challenges in adult age group is, of course, overzealous hygiene, a lot of hand hygiene, a lot of use of disinfecting soaps. It's not, we have to tell the parent or the patient that it's not important to actually use disinfecting antiseptic soaps, but a gentle cleanser will also do the job of removing the microorganisms. Then a lot of wearing of masks. So we have seen an increase in patients who come with perioral dermatitis since they wear masks for long hours. Then sweating for healthcare workers who are atopic. We all know sweat can aggravate itching and atopy. That's a major challenge in healthcare workers. There is an increased use of hand sanitizer. There is again a period of physical inactivity. So if people gain weight or their diet becomes westernized, we are going to see more eczema. And comorbidities is a very big challenge in an adult patient who's suffering from atopic dermatitis. So what would be the new rule book? As of now, we have yet to achieve a consensus guidelines on management of atopic dermatitis, but possibly there is an increased risk of developing infection through the skin as the skin barrier is impaired. So we also have to emphasize preventative measures like wearing a mask, wearing goggles or eyewear to prevent COVID infection. Now, in especially Western countries like UK, they are advising something known as shielding. So we all know about social distancing. Shielding means if you're extremely vulnerable, you should stay at home and keep your interactions to outside to a minimum. They are also advocating shielding for patients who are on immunosuppressive medication. Third is contact dermatitis. We all know people are washing their hands more and they should do that. But what we saw in a study, this study comes from China, where they saw 2/3 of healthcare workers, they wash more than 10 times a day. Only 22% apply a moisturizer. So with COVID, there is a renewed interest and emphasis on non-pharmacologic intervention. We also have to understand that parents will be skeptical and have a right to be skeptical if you talk more of starting them on immunosuppressive medication. There is an enhanced role of topical therapy. There is an enhanced role of non-pharmacologic intervention. Sadly, I feel most of the doctors do not spend time, or there is a paucity of time to, when it comes to counseling a patient about it. But this is the game changer of treatment of an atopic dermatitis patient. And I feel adequate time should be spent. If you have paucity of time, please keep some leaflets ready in the language understandable to the patient. You should hand it over to them. We have the power of social media to generate awareness. So barrier repair therapy is very important. The production of new moisturizers which contain ceramide, or pseudoceramides, or, some moisturizers even claim to have things like oat extracts, which have anti-itching properties. They are a game changer. And in my practical experience, though we do not have a consensus clinically, there is no evidence to say that one moisturizer is better than the other. In my practical experience, I find ceramide containing moisturizers to be slightly more effective than conventional moisturizers. But as I said, in case there is an economic issue, try to use a moisturizer which has an emollient with an occlusive or humectant action. They improve the barrier function, they strengthen the wall, and studies show that, as I already talked, there's almost a 50% reduction of risk. It is very important to sensitize parent or patient to the importance of a regular moisturizing regimen. So, I already talked soak and seal. Take quick bath, pat dry, seal it with the moisturizer. Re-emphasize at every visit or every online chat that you have with the patient. Now, proactive versus reactive approach. Conventionally, I will talk of reactive strategies, that when a patient comes to you with an exacerbation, you make them apply, emollients with or without antibacterials, with some symptomatic treatment that consists of topical steroids in the beginning, and use or topical calcineurin inhibitors on a needed basis. Proactive approach is the need of the hour. So we start with an intensive anti-inflammatory therapy. We bring the lesions down, the clearance of lesions, and then we follow it with the long-term, low-dose, intermittent application. We call it as a weekend therapy. 2 days a week, patient has to use the low-dose, anti-inflammatory agent. And my personal favorite is a calcineurin inhibitor. Also emphasize daily application of emollients to unaffected areas. Tell patient it's an entire field. The crop of lesions can come anywhere. Continue to moisturize and enrich the barrier, and give them a weekend maintenance therapy, and tell them that in case they expect an exacerbation, they should start using it before the lesions actually become active. So proactive approach, I re-emphasize, is the need of the hour. Now, in proactive approach comes a greater role of calcineurin inhibitors versus steroids. Why would I say that? Because evidence points to certain things. We already saw this slide where we found pimecrolimus and tacrolimus is more selective on their action compared to corticosteroids. So if you look at this picture, so these are the two pictures where we have seen the extracellular lipid bilayer. This is a picture of after using betamethasone treatment. You can see irregular skin barrier. There is a disrupted lipid bilayer compared with pimecrolimus, where you see there is also a formation of regular and continuous structure of the lipid bilayer. So pimecrolimus improves skin barrier. That is the reason people or patients rebound a lot after usage of steroids for very long, because steroids not only cause atrophy, they also disrupt the lipid bilayer. Let us see what the evidence says. Evidence says that betamethasone, or that's just one of the potent steroids commonly misused by patients, it decreases the enzymes for lipid synthesis, whereas pimecrolimus has no impact on it. So steroids can cause a significant reduction in the lipid barrier, whereas calcineurin inhibitors will not. So what do we prefer for long-term management? Something that aids or improves the barrier of skin. So we can see, we already saw this. So this may explain the lack of restoration of stratum corneum layers, and I already talked that pimecrolimus can actually aid us in more ways than just reducing inflammation. Acceptability of patient also in studies has been found. If you compare topical steroid in yellow with blue pimecrolimus, we find more easy to apply, and there is less concern with pimecrolimus when you have to apply on sensitive areas like face. There is a good tolerability. If you look at tolerability profile, improvement in quality of life and well-being, it's much better with pimecrolimus. It also helps in good disease control and stabilizes the skin lesions. So efficacy of pimecrolimus and tacrolimus, pimecrolimus 1% and tacrolimus 0.03%. So pimecrolimus, and in my practical experience, I fully support the study when it says that pimecrolimus tends to have a greater effect on head and neck than tacrolimus, and in certain areas like trunk, it supersedes tacrolimus and body application. But most of the studies point similar efficacy to pimecrolimus cream 1% and tacrolimus 0.003%, and with better acceptability rates for pimecrolimus. So acceptability by the patient is also more. If you compare two calcineurin inhibitors, pimecrolimus and tacrolimus, the non-greasy characteristic of pimecrolimus makes it very acceptable to patient. There is less stinging and burning with pimecrolimus compared to a tacrolimus. Of course, you have to pick up a good brand of pimecrolimus because it is the formulation that matters. So as we see, the patient related characteristics like ease of application, spreadability is all good for pimecrolimus. It scores slightly higher over tacrolimus. The burning sensation, as we can see, is less with pimecrolimus compared to tacrolimus, 0.03%. Of course, tacrolimus 0.1% because of its strength causes more burning sensation, and it's not advocated for children people less than 16 years. So systemic exposure is a concern in most of the urban parents, and you can tell them, show them that tacrolimus was detectable in 36%, pimecrolimus in only 10% of patients, and systemic exposure to tacrolimus is slightly higher than pimecrolimus, but both of them fall under the safe zone. Now, risk of cancer is not supported by any epidemiological data, and we are talking of evidence that that is credible. It has been seen that maybe cutaneous T-cell lymphoma can mimic adult onset atopy, and that's the reason of inaccurate reporting. So rapid induction of lymphoma is not possible, and topical treatment, as we already see, it results in minimum systemic absorption. So there is no evidence that lymphoma can be caused by topical calcineurin inhibitors. It is high time we adopt them because of the benefits I discussed before. High-risk patients of atopic dermatitis. Now, how do we label them? Who are the patients who are at high risk in COVID era? Patients who are taking 2 or more immunosuppressive medicines, except if one of them is hydroxychloroquine. People on systemic steroid of even 20 mg or more for more than a month are high-risk patient, because steroids increase the risk of infections. We'll talk about it. People who take steroid dose of more than 5 mg each day for more than a month, plus they are using some other immunosuppressive with it, are also at risk. People who take cyclophosphamide, rituximab or infliximab, people who are on single immunosuppressive or biologic medicine, who are over the age of 70, they're pregnant, they have a comorbidity, they are high-risk patients. Now, if you see the phase 3 clinical trials of the conventional immunomodulators, methotrexate and cyclosporine have not been seen to be associated with a lot of risk of infection. There's a very minor risk of infection. We already talked that cyclosporine is possibly having a role in coronavirus infection treatment, as seen in vitro. Azathioprine can pose moderate risk. Mycophenolate mofetil has again can predispose to a moderate risk of infection. Hydroxychloroquine, as we all know, is not so immunosuppressive in its mode of action. So there is no need of panic in every patient. How do we assess the patient? How do we, there's a lot of questions coming in my fraternity, that how do we manage a patient who's already on immunomodulator? We'll be talking about the international guidelines. I'm quoting the Australasian College of Dermatology. They say that if patient is 60 plus and is having comorbidities, is on multiple doses of immunomodulators, they are having a high risk. But for low risk patient, continue immunomodulator, and we will see how we manage the dose. Corticosteroid is very immunosuppressive at dosage above 20 mg. Avoid long-term steroids. Remember that if you're giving a corticosteroid, even at 15 mg for 3 weeks, it is having an action on adrenal axis. If Australasian College recommends against sudden stopping of steroids, we know if you suddenly withdraw steroids, it can land the patient in Addisonian crisis, which is worse. It's important for patient to have a card where it's clearly mentioned that patient is already on a steroid dosage from a long period of time to help the physician. So it might be needed. We all know that if such a patient falls into physiological stress like COVID-19, they may actually need to continue steroids. And if reduction is indicated because the patient is very high risk, please aim for a gradual reduction. Do not reduce the medicine all of a sudden. Now, patients who are on immunomodulators with a URTI, if patient develops signs and symptoms of upper respiratory tract infection, you consider reduction of dose or stop it for 1 to 2 weeks. Screen them for pathogens. If you can also refer them for COVID-19 testing. Now, what do we do if a patient is on immunomodulator and we suspect or it's a confirmed COVID-19 infection? All immunomodulators should be withheld, except steroids, I already said. For patients on a biologic agent, you cannot stop it, but you can postpone the next dose. It says that you postpone the next dose if it falls within 31 days of infection on base potential and shedding. Recommends biologic only if you have confirmed negative PSR indicating no viral shedding. Conventional immunomodulators should be withheld for 31 days from infection onset and recommenced only if RT-PCR is negative. Please indicate a high index of suspicion in such patients. So how much to lower down the dose if it's an azathioprine? I think this is a useful table. We can accordingly reduce it to less than or equal to 0.5 mg per kg. Cyclosporine and can also be reduced to less than 1 mg per kg per day. Prednisolone, as I said, can be reduced gradually to 10 mg per day. Retinoids, as of now, there is no consensus whether we really need a dose adjustment with it. And biologics, we talked before. So, how to initiate an immunomodulator in an atopic patient during COVID-19? Until further evidence is available, the ACD recommends against starting a patient on new immunomodulator. Initiation of immunomodulator, if a patient is suffering from a severe atopic dermatitis, there should be an informed decision. Patient should be made aware of the risks and benefits. Caution should be exercised if you are initiating, something like a TNF alpha inhibitor, rituximab. Some college of dermatologists recommend against starting them. Consider starting them in very low dose. And it's important that you follow up patients if they are on immunomodulators. You have to, we also have to consider the rational use of healthcare resources. You have to do, we should try to do follow-up visits using telemedicine, and we have to reduce the frequency of monitoring investigations or lab tests, and we have to reinforce the patients to improve comorbidities. And all of this ACD strongly recommends to take in writing from the patient. Now, what is the statement of International Eczema Council regarding management of atopy in COVID-19? Now, they say, and most of the evidence says, that uncontrolled asthma is also a risk factor for more severe COVID-19 pneumonia. So they recommend against stopping treatments all of a sudden. In certain patients who have asthma or who are on medicines like dupilumab, I told that dupilumab is a very cytokine-specific medicine. It doesn't impact Th1. It only impacts Th2. They recommend not to stop dupilumab, considering and to continue the systemic treatment. Dose tapering may be required, especially with steroids, but caution should be exercised, for rapid reduction can lead to aggravation of respiratory symptoms, and which may also increase the risk of the COVID-19 pneumonia. So another factor for consideration of risk is whether, as I already discussed, most of them do not have a very increased risk of viral infection, but we do not have any practical experience as of now of handling patients when they were on these medications. Patients with significant respiratory comorbidities have a higher risk of COVID-19 related complications. And as the pandemic develops, we should monitor further to developments in the understanding of interactions is yet to come. Now, the European Task Force also advises to continue all immunomodulating treatments, including immunosuppressives, because exacerbation of atopy can have a negative impact on the immunity. Follow the guidelines, observe hygiene, observe social distancing, and shielding of such patients. And as we said, that these drugs may also affect the severity of comorbidities. Do not abruptly stop. It can actually trigger asthma, COPD, or eosinophilic esophagitis in a predisposed patient. If systemic treatment needs to be paused, patient has to be supplied with ample topical therapy and a guidance how to manage the flares, and continue to monitor their especially patients who have atopic triad. We have to also monitor and treat comorbidities like asthma and allergic rhinitis. They should ideally be managed in a tertiary care center. So can we predict interactions of atopic dermatitis, complications, and therapies with COVID-19? As of now, a disseminated viral skin infection observed in atopic dermatitis patient, like if a patient actually gets herpes zoster, eczema herpeticum, or nasopharyngitis, theoretically it may increase the risk of COVID-19, but there are very limited conclusions drawn. Targeted treatment like dupilumab is safe because it doesn't increase the risk of any infection. Cyclosporine is also possibly coming up as a treatment for COVID-19. But none of this has a robust clinical backup to become a recommendation. The takeaway message is that looking at how the corticophobia, the covidophobia, the practical implications, there has to be more emphasis on non-pharmacologic intervention. There has to be a proactive management of eczema rather than relying on reactive approach. It is important we reach out to the parents and the patients and tell them to start using a calcineurin inhibitor 2 days a week to prevent a flare-up rather than to come with a reaction. an exacerbation. Greater role of topical therapy is what I see in the coming days of COVID-19, and a much greater role of sensitization and counseling. As I said, the non-pharmacologic intervention is the pillar of treatment. It has always been the pillar of treatment, but in COVID-19, it assumes a new role and importance. Thank you.
Thank you, Doctor. I think it was an amazing session and very, very insightful. I'm sure our audience must have definitely been enlightened with the session. We will now move on to the Q&A round. Our first question is from Dr. Akshay from Delhi. How different is the treatment plan for a patient with AD in mild to moderate cases for adult and pedia patients?
I think, Dr. Akshay, as we talked during the presentation, the topical therapy is something that we always emphasize for mild to moderate patient. But it is time that we sensitize them to we all know as practitioners that patients tend to be non-compliant to something like a barrier repair regimen. So it's important that we actually, give them, handouts and, use social media to make them continuously apply possibly a ceramide containing moisturizer. Second, as I said, a proactive approach is mandatory. It is important for us to maintain the patients who are doing well, especially if they're suffering from mild to moderate atopic dermatitis. In my personal opinion, I prefer starting off a calcineurin inhibitor at the same time we are treating the flare of the patient. So it's very important that you introduce it early in the treatment. And also, we should use more of wet therapy, possibly even bleach baths, something that we never, I think, really focused upon. So it has assumed a bigger role. So we can use short course of steroids, but as I already discussed, oral steroids can be immunosuppressive even in less doses. So maybe a 5 to 7 day course is okay, but try not to prescribe too much of oral immunosuppressive medication. If the patient is already on it, and I'm sure we do not prescribe too much systemic therapy for long period in a mild to moderate case, so they can be better managed. Introduce calcineurin inhibitors early. Introduce the soak and steam approach. Emphasize it more. You can also take up wet trap therapy, which I've started doing in my practice, and I find it actually improves the quality of sleep and quality of life. So wet trap therapy we discussed, putting medication in areas where the lesions are very easy. On top of that, cotton bandage of moisturizer, and then dry. So it is really important in COVID-19 in mild to moderate cases.
Thank you, Doctor. Moving on to the second question, it is from Dr. Priyesh from Luthar. When is antihistamine prescribed in the entire treatment algorithm?
Actually, thank you for pointing out, doctor, because I did talk that itch management is the management of atopy. And it's very important we sensitize, but I skipped that point in my presentation, I admit. Antihistaminics actually have an underrated role in atopic dermatitis. They are the true steroid sparing agents. And it is very mandatory that I think right from mild atopy to the severe patterns, antihistaminic should be prescribed in the beginning, because it is the thing that's going to improve. So as I said, itch management is the most important part, not the clearance of lesions. So I think if you talk of an algorithm, antihistaminics will start from day one. And we all know that we always prefer a non-sedating antihistaminic in less than a year or 2 year child. Then there is also a greater role of Montelukast coming up, especially in adult patients. I find antihistaminic with a Montelukast combination works like a magic, because as the quality of life improves, quality of sleep improves, stress goes down, indirectly it helps atopy, directly it reduces itch, it helps atopy. So I think it should rank higher, though none of the algorithms are talking about it, but as you rightly pointed out, they are one of the important pillars of treatment along with the barrier management.
Moving on to the third question. Um, Why is the scope of pimecrolimus limited in AD? This is a question from Dr. Radha. She's from Pune. Doctor, you're on mute.
Please say it, repeat the question.
Yeah. This question is from Dr. Radha. Why is the scope of pimecrolimus limited in AD?
Dr. Radha, I think it's more of a awareness and sensitization part. We always lacked good formulations of pimecrolimus. I personally, in my practice, use pimecrolimus in and out. Their role has been mentioned in literature as pimecrolimus is taking over, even tacrolimus in the management. It has a limited role because probably we have a limited prescription of it. We prescribe it, but I would say it plays a good role. It's very important, especially for patients infantile eczemas, perioral facial involvements. Pimecrolimus, as I already showed you evidence wise, has a greater role than pimecrolimus. It has been found to be even better than topical steroids. The idea is to introduce them early. Always introduce it in the beginning of the therapy when the patient is on topical corticosteroid. One, the burning and stinging sensation with pimecrolimus and tacrolimus goes down if a patient is also taking a topical steroid. Second, as I talked of proactive approach, it becomes easy for us to tell the patient to continuously keep on applying for 2 days a week. I would say it has a much greater role, and we should all start prescribing calcineurin inhibitors. The fear around it is probably overemphasized. A good formulation of pimecrolimus also, it's my personal opinion, causes much less stinging than a bad formulation. So choosing the right formulation of a calcineurin inhibitor is important. Telling the patient, addressing their concern about safety of pimecrolimus is important, and early introduction of calcineurin inhibitor is very, very important when it comes to AD management.
Thank you, doctor. We move on to the next question. When do you prefer to use tacrolimus, TCS, and pimecrolimus? This question is from Dr. Raman Raj from Chennai.
Dr. Raman, I think for areas like elbows and the popliteal fossa or extensor aspects, I would prefer tacrolimus, especially in adult patients. In pediatric patients, I have seen better acceptability of pimecrolimus, but and we know that in infantile age group we generally have lesions more in flexures and face. So, but in an adult patient, tacrolimus is something that I would prefer over pimecrolimus. In the if you talk of the site of lesions, if the site of lesion is extensor aspect of legs or the hand eczemas, I think I would always prefer tacrolimus. So based on the site of the lesion and age, I prefer tacrolimus. But pimecrolimus for kids and tacrolimus for adults, and tacrolimus even in children who have it on childhood AD, where we see a lot of patients on knees and elbows, tacrolimus can be preferred over pimecrolimus.
The next question is from Dr. Harish from Jamshedpur. Post COVID, how do you think will patient inflow increase for AD?
I think, Dr. Jagdish, post COVID and during COVID, we expect a surge of patients of atopy because we both know that since COVID has started, first thing that our dear patients do is to start taking more bath, despite us counseling and sensitizing to them. So I think during and after the COVID, atopy may increase. As I said, more sedentary lifestyle. People will also get used to working from homes, and maybe that is the new norm now. So and there is I'm sure we as parents also would not encourage too much of physical activity outdoors. So all these pointers are predicting towards a surge of atopy, and I think that's going to be the next challenge for all dermatologists and practitioners alike. I think the cases might increase during COVID. We've already started seeing, and post COVID all the more. And add to it COVID related stress, and we see an increase in itchy disorders of all kinds.
Moving on to the next question. What type of emollient would be ideal for treating AD? Is there any particular brand preference?
See, doctor, though it's difficult for me to name any brand, but though evidence says that no moisturizer is better than the other, but in our experience, we have always seen that it is high time we realize that coconut oil is just a occlusive. Paraffin and liquid paraffins and petrolatums are also occlusives. So, as I already said, a good moisturizer is something that goes into the skin. So, for going into the skin, a good moisturizer should have ceramide or a pseudoceramide component in it. Ceramide 1 and ceramide 6 are the two most important ceramides. So, a lot of people approach us and say we have a ceramide. It's important the type of ceramide. Ceramide 1 is most important, followed by ceramide type 6. So, it should ideally have that along with a glycerine component, along with a petrolatum component. So, it goes inside and it also preserves the natural moisture. So, it replenishes and preserves at both times. Ideally, it should not have, of course, I'm sure we know, it should not have parabens, it should not have fragrance, and it is also very important. The certain moisturizers which contain anti-itching components like oat extracts and substance P inhibitors. There are certain international formulations which do help in especially improving the itch component. I would prefer that in an affording patient. But in a non-affording patient, we have a lot of pharma companies coming up with good ceramide containing formulations. We should look out for them. Things like
Thank,
shea butter and glycerine only have a humectant action. So if some patient is not affording, we can go for moisturizers containing shea butter and things like that, especially if the skin is very scaly.
Thank you, doctor. Moving on to the next question. Any changes in diet that needs to be done for an AD patient? This question is asked by Dr. Preet from Delhi.
Dr. Preet, that's a very wonderful question, I must say. As I already said, that with people sitting at home and eating refined sugars and saturated fats, that increases obesity. Anything that interferes with metabolism is going to aggravate atopy. So, a low carb, high protein diet is a must for a patient, especially adult patients. And though these are anecdotal evidence, but there is an important role of omega-3 supplements in patients who have atopic eczema. Diets containing essential fatty acids like linoleic acid have seen to be important. Encourage patients to have prebiotic and probiotic. Though we don't have evidence to say that they are a treatment, but encouraging a probiotic rich diet, things like curd and buttermilk. In India, people have an aversion towards it. There's a myth that curd is going to cause cold and cough. So it is important for us to emphasize to the parent that a prebiotic, probiotic rich diet works at the gut level. And gut impacts skin. We know that, but sometimes we have to let the patient know. So I would say a low carb, high protein diet, a high fiber diet, a probiotic, prebiotic rich diet, omega-3 fatty acids in the diet would be an ideal diet for an atopic patient.
Moving on to the next question. How frequent are you seeing AD patients with allergic rhinitis in less than 5 years kid? This question is from Dr. Manish from Delhi.
Uh, Dr. Manish, I think I see a lot of atopic triad primarily because I practice in Bangalore and Bangalore is a dry weather place. So even in summers, we have to take out blankets. It's a chill and it's a low humidity temperature. And most of the people stay in, because of that reason, we see a lot of allergic rhinitis. In my practice, I would say almost 50% of my patients have atopic triad, something like allergic rhinitis and asthma.
Next question is from Dr. Arpita. What should be the duration for the usage of pimecrolimus in moderate cases?
Dr. Arpita, there hasn't been a consensus on how many weeks to months we can continue, but what we have, what the evidence points out, is that you can use it as a maintenance therapy for very long. because there's no risk of atrophy, there is no risk of even damage to skin barrier. Only thing is in moderate atopic dermatitis, you have to go for intermittent therapy if you are planning a long-term maintenance. So after the clearance of lesion, 2 days a week or 3 days a week is not harmful. So it's difficult for us to say that for this many months, but a weekend maintenance therapy can be continued for up to 6 months. There is no consensus on this statement by the clinicians, but in my personal opinion, I have used it for as long as 6 months. There, you definitely have to give a skin holiday first few weeks in between.
Thank you, doctor. Our next question is again from Dr. Arpita. Any safety and scientific validity of efficacy of apremilast in recalcitrant atopic or contact dermatitis patients?
But Dr. Arpita, it's a very good point, I must say, because we did not talk about Epidemiolab because there's not much noise around it in international literature. But I did come across a couple of papers showing that it may become important in the coming days, as it's a non-immunosuppressive medication. But apremilast theoretically does not have much benefit on the TH2 subtype of immunity, and possibly this is the reason we do not have much buzz around it in a atopic disorder. So, in my personal opinion, now that's again a theoretical. I do not have a practical experience of using apremilast in a contact dermatitis patient. Something that is working on TH1 phenotype disease like psoriasis, how effective would be if you look at the mechanism of action. So, but there are papers coming up that whether these non-immunosuppressive immunomodulator agents can have a greater role in managing it.
Thank you, doctor. Moving on to the next question. Advice on vaccine schedule for AD patients in children. This question is from Dr. Prabhakar from Bangalore.
Dr. Prabhakar, I personally have not read about specifically how to, about the vaccine schedule in an atopic patient. But my personal, I would say from my theoretical knowledge, there should not be stoppage of any vaccine schedule, though I do not claim to have read a paper on it. But I personally feel that vaccination, though vaccination uh, always aggravate atopy in certain patients, but the risk benefit ratio would always favor a vaccination over an exacerbation of atopic dermatitis. I admit I have not read any evidence on this. I'll surely read up to and read back to you. But I would always say risk benefit ratio of vaccine is always higher in the pandemic, especially in tilts in favor of continuing with the routine vaccinations.
Thank you, doctor. Moving on to the next question. It's from Dr. Arpita from Bangalore. Do you practice usage of colloidal oats for skin barrier effects and anti-inflammatory action in eczema patient? Do you see any difference in the efficacy of oatmeal moisturizer versus ceramide emollient?
Dr. Arpita, that's a very good question. Most of these oatmeal preparations also have ceramide in it. So my practical experience has been very good with something that has anti-itching properties like oatmeal extract containing moisturizers. And I definitely see a benefit. Most of them have a ceramide in it. So I can't compare oatmeal extract versus ceramide. Most of them have combination of it. But I definitely find it advantageous to use in patients over conventional moisturizers. So conventional moisturizers, would mean the paraffins and the other occlusive inactive agents or shea butters. I prefer, and I definitely feel there is an upper hand of ceramide and oatmeal containing extract, especially when it comes to improving each component of the protein.
Thank you, doctor. Moving on to the next question. How do we maintain balance? Prescription of steroids in COVID times is risky. Should we restrict just to itch management? This question is from Dr. Radha from Panchkula.
Uh, Dr. Radha, I personally feel this we have to be cautious while prescribing oral steroids because all international evidence is pointing that oral steroids have definitely increased the risk of infection. There is a limited role of using topical steroids to come or prevent or come over the flare part, antihistaminics are underrated, as I would say. They are, as one of the worthy doctors also asked this question, antihistaminics. I can't say they can replace steroids, but in a COVID era, yes, they assume their importance. Good itch management, just the way surgeons have taken over, pain management has become very important in all surgeries. Itch management is very, very important for atopic patients. And though antihistaminics cannot control 100% of the itch, we all know that. But in a COVID-19 where we are getting used to new compromises and new adaptations, usage of antihistaminic with a very strong topical regimen is definitely helpful in managing most of the mild cases.
Thank you, doctor. There's one more question from Dr. Sameer. How often do you go for biologics for managing AD, and how is the response compared to topical therapy?
Dr. Sameer, I have not used any biologic agent as our center is not having what you call an attached hospital with it. But I have a very limited experience with biologics, but I have used cyclosporine. Results are great. It's not a biologic though. The results are great. Only problem is maintenance because frequently our patients drop out because of the good amount of lab monitoring that is required. I feel cyclosporine is a wonder drug when it comes to managing moderate or I can say severe atopic dermatitis. But there is always a compliance issue with systemic therapy when it comes to the childhood or infantile age group, especially childhood age group. I have very limited experience of using biologics personally in atopic dermatitis.
Thank you, doctor. There's a second last question, and this question is from Dr. Manish. What are the new molecules that you are seeing new hope in treatment of AD patients along with TCI or monotherapy for the management of atopic dermatitis?
Dr. Samir, actually, that's a very wonderful question. I must appreciate you. Dupilumab looks so promising that I would say I would be eager to try that. Something so specific against interleukin 31 and interleukin 4, which is the pruritus causing cytokines, which does not impact the immunity, which does not predispose to the risk of infections. I think dupilumab is the new kid on the block. We should look forward to it, especially looking at COVID-19. Second is the topical phosphodiesterase inhibitors like crisaborole. They have shown a good, improvement in moderate to severe AD in phase 3 clinical trials. So I'll be looking forward to topical phosphodiesterase inhibitors. So I think dupilumab would be my personal favorite.
The next question is from Dr. Shreya. Any difference in the patient inflow during COVID-19 pandemic for AD, contact dermatitis cases, and seborrheic dermatitis cases?
Again, that's a good question because I think you have already nailed it, doctor. These are the three things that we are seeing more. We see a lot of contact dermatitis, especially in hand eczemas. We are seeing a lot of flare of atopic dermatitis in children. And I personally feel that there has been an increase in rise of seborrheic dermatitis patients in the last few years. And we all know that atopic may start 3 months or above, but SD starts early. So a lot of patients of seborrheic dermatitis, atopic dermatitis overlap in the COVID-19, possibly because people are sitting at home, they do not walk the head of the child. Indians always feel oiling the scalp increases immunity of children. The certain cultural traditions where we feel putting gingerly oil on the head is going to increase immunity, prevent cold. So because of that, I think there is a increase in seborrheic dermatitis as well.
The next question is from Dr. Meeti. We found that brands of pimecrolimus and tacrolimus with paraffin base or humectant base gives better results and prevents dryness with patient compliance. What is your feedback?
I agree with you, Dr. Neeti. As I said, formulation is what makes the difference. Just as all brands of cars are not same, all formulations are not same. So definitely something that is in a emollient base would be helpful. Not only pimecrolimus and tacrolimus, even steroids which come with peanut oil base work better. than normal steroids. Steroids with ammonium lactate as a base would work better in an atopic patient, adult patient. So I definitely agree with you that if the formulation or contains a moisturizing base, acceptability and ease of application. See, theoretically we may talk of good results, but if patient is getting stinging sensation on application, it's difficult to convince them to continue with the treatment. So I agree with you that a calcineurin inhibitor with a moisturizing base is much better than to use something that doesn't have a moisturizing base.
Thank you, doctor. Next question is from Dr. Prabhakar. Risk of bacterial and viral infections in patients on topical TCI.
So that's a very good question, and we know that PCIs have one what we can't call it as a negative impact, but PCIs do decrease antimicrobial peptides, and the risk of getting viral infection or bacterial infection is slightly higher with the long-term PCI. So that is one word of caution possibly I missed. Thank you for pointing it out. Theoretically, the risk of viral infection, bacterial infection, is more with a calcineurin inhibitor than even a steroid because of their effect on antimicrobial peptides. So we have to keep it in mind, and especially if a patient is atopic and is suffering from viral warts or molluscum contagiosum, then comes the real problem: how to manage their eczema with a coexisting cutaneous viral infection. Their calcineurin inhibitor scores less than a steroid. I agree.
Thank you, doctor. Our last question is from Dr. Arpita. Have you used potency corticosteroid like Disonide in adults suffering from seborrheic dermatitis AD? What is the duration of usage of Disonide in pediatric population?
There are no consensus. We say that how many weeks we can, but we can always use a compound like Desonide to in a in infantile age group. I would just use it for, say, I have never used it beyond 2 weeks as a principle, because I think it's very important for us to do that, because the problem is that parents might misuse it. And I introduce pimecrolimus very fast in a patient of SD overlap, especially for facial and extra scalp involvement like body areas. Pimecrolimus, another very important thing, Dr. Arpita, seborrheic dermatitis, especially STAD overlap in infantile age group, they come with hypopigmented patches. So they may not always have red scaly patches. They come with hypopigmented patches on the chest and face. And if you give Desonide or any other steroid, it worsens that white color, increasing the scare amongst the parents. So this is one point why we should prefer for extra scalp areas pimecrolimus over a steroid from the beginning. So you may use a topical steroid of low potency for a couple of days or weeks on the scalp. Also on the scalp, add ketoconazole 2% early in your prescription for maintenance. Maintenance is the key, and the idea is to introduce it early. So I would prescribe a Desonide for the scalp for a couple of weeks, but with Desonide, I co-prescribe a ketoconazole 2% for the scalp. And for body, in infantile age group, I prefer pimecrolimus from the beginning. A good formulation has better acceptance than even a steroid, because it also helps in improving the whitish discoloration. So parents are very happy.
Thank you, doctor. There's one more question. This is from Bangalore. Do you prefer using sulfate-free, paraben-free emollients in AD cases?
Uh, Sulfates are basically detergents. I would say I prefer a sulfate and paraben-free washes. Emollients, of course, parabens-free, fragrance-free, but when we talk sulfate-free, that means we're talking of a detergent action. I would always prefer a body wash or a soap which is sulfate-free and parabens-free. It goes without saying, though we don't know, evidence doesn't point that they have a beneficial effect. But theoretically, because your barrier is impaired, it is good to prescribe minimum preservatives and, to prevent allergenicity in the future.
Thank you, doctor. With this, we can close our Q&A. It was indeed a wonderful session, I must say. Our audience are definitely, they have been boosted with a lot of knowledge. It was pleasure having you as a speaker, and thank you very much.
Thank you, Apeksha, for your kind words. And I thank Mylan for giving me this opportunity to present such an interesting topic. Thank you.